I would like to thank Aaron, my friend, for inviting me and putting this curriculum together for us. And I apologize for the morning. We have 4 young kids, and you never know when you're going to have emergencies. But I guess at least they're not teenagers yet, so I was able to make it here. But thanks for being understanding. So our approach Uveal Melanoma as a multidisciplinary team at the Cleveland Clinic, and Dr. Singh is our coordinator, and we have me in the team as the surgeon, Dr. McNamara as the oncologist. We also have our radiologists who are not here, who are also helping with patients with more advanced liver involvement, and we try to form a really close relationship with our patients and figure out at one certain time points what the best treatment for that person would be. We don't see each other as having a hammer and just hitting every nail with the hammer, but try to figure out which treatment would be best. So my specialty interest is developing minimal invasive liver treatment options, and I'll give you some examples and give you details about the procedure and also some of our results here. We know that as a uveal melanoma specialist, we have to pay attention to the liver because about half of the patients develop liver spread over time. And in most patients, the liver is the only organ of involvement. So it's some value in considering liver-directed therapies. Traditionally, the patients with liver tumors undergo these big operations where you make a big incision and try to cut these tumors out. But thanks to technology, we have replacing these treatments with less invasive treatments. We can still go in and cut these tumors. Also, we also have other options, including robotic surgery, or I'm going to talk to you about, or you can burn these tumors with a special needle, and you don't have those big incisions, you don't have that big recovery. Most of these patients are able to go home either the next day or in a couple of days, and that these treatments are effective as making a big incision and cutting them out. So how are these procedures done? This is, for instance, a radiofrequency ablation procedure. I thought maybe you might find this interesting. Let's see. Okay, this is working. So when we are in there, this is the ultrasound probe. This is the liver. This is the tumor inside the liver. You can see we insert this special needle, and it has these prongs that you can deploy like an umbrella. And then once you run the energy, you basically heat this tumor, and if you can heat it well enough, you will destroy the cell membranes, and these tumors will die. And this is how it will look afterwards. And it will take a couple of minutes, and you only have those 2 small incisions. Each one is half an inch. As you can see, you preserve the liver, and you're all able to treat the liver minimally invasively with this approach. And this is how it looks afterwards. We have used this, we're using this technology not just for uveal melanoma metastasis to the liver, but for a lot of other disease conditions. And I wanted to show you the breast cancer because breast cancer has a lot of similarities to uveal melanoma because it tends to be systemic, and you don't have like a one straightforward option for any given patient. And showing you the results here, and I explain what this slide shows. So when we evaluate the efficacy of a treatment for a patient with cancer, we try to see if we can help with the patient's overall survival. And you can see this is months about how these patients survive after you start their treatments. And this is systemic therapy. For breast cancer, there are a lot of treatment options, including hormonal agents and chemotherapy agents. And this is the group of patients that we have treated these patients also with liver-directed therapy, the radiofrequency ablation. When we looked at the experience at the Cleveland Clinic, we looked to see what the characteristics of our patients were. First of all, you cannot do this treatment to every patient. There are some indications. The liver involvement has to be a certain pattern. You should not have too much disease outside the liver. So when we compare those patients to those patients with similar tumor characteristics and tumor burden who underwent systemic therapy alone, you can see that those patients had liver therapy, they live longer. So there was some benefit definitely of considering liver-directed therapy to the patients presenting with liver-only disease and not just treating them with systemic therapy alone. Based on these good results with breast cancer, we looked at uveal melanoma together with Dr. Singh and Dr. McNamara, and I'll summarize these results with you. So in this study, we looked at 16 patients who had surgical treatment of their liver disease. And then from Dr. Singh's database, we identified 28 patients who had systemic therapy. This was between 2000 and 2015. And then just looking at how are these patients different, these are some patient demographic information. You said patient age, gender was not really different. Their primary tumor treatments were not different either. What was different is that the patients we treated with surgery, they had less number of tumors. This is probably acceptable because for any liver-directed therapy, you don't want the whole liver to be replaced by the tumors, but you have some certain criteria. For uveal melanoma, we would say that less than 8 lesions and less than maybe 25% of the liver volume to be covered by this tumor. These are the same for breast cancer as well. And looking at these results, so these were the patients, and then when we look at their patients' overall survival, the top line is the patients who had surgery as in addition to systemic therapy, and these are the patients who just had systemic therapy alone. So you can see that there was a striking difference in the patients' outcomes, because the patient who had liver therapy survived in the longer years than the patient who did not. If you wanted a number, I would say like the patient who had surgery, 22% of those patients were alive after 5 years. And then we do a lot of sophisticated statistics to make sure that we're not really manipulating the results with statistics. And we put all of these risk factors, and surgery was again a beneficial treatment option for these patients. So why did these patients do better with surgery? They probably had more indolent disease than the other patients. But again, it also demonstrates that if you are a patient who has a slow-growing cancer and you have a limited liver involvement, you should be given the option to have these treatments done. And when the patients present, if they present too much disease, then we perform these radiation seed treatments, which is called TheraSpheres, where the radiologist goes through the groin, finds the blood vessel supplying these tumors, and injects them with this radiation beams, then you can have a more diffuse treatment of the liver disease. So some of the patients in the systemic group had this treatment done when they had progression of disease. So our result here confirms that if you have liver involvement and you have limited disease, and especially if they've been a long interval since the diagnosis of primary, treatment of these tumors minimally invasively would benefit with your overall outcome. And I'll show you some of the other treatments. This was a patient with uveal melanoma, for instance. This is the liver. This is the left side of the liver. And he had 3 spots in the liver. And showing some of the details, I thought maybe you might find it interesting and maybe also not falling to sleep after lunch. So when we go in, we always look at the liver to make sure that there's nothing else. This is ultrasound. We can see more with ultrasound at the time of surgery. And you can see this white area is tumor, the gray area is normal liver. We always use ultrasound because we can find more tumors sometimes. And then there's some energy devices we use at the time of surgery. There are some bands that connect the liver to the abdominal wall, for instance. You have to divide them. There is a critical vessel here that you have to stay away from it. So this is all done with a magnified view. And afterwards, after we mobilize the liver, this is our line that we're going to cut the liver with. So as I showed you, you don't need to have a big incision to do all of these. We have these laparoscopic options now. We can do it. So then afterwards, you have these energy tools that you use. When you do liver surgery, you have to make sure that you can secure the blood vessels and the bile ducts that go through the liver. So you need to have all these tools. And then we have a lot of advanced energy tools. This is one of the newest devices. It just simplifies this procedure significantly. It uses what we call radiofrequency energy, and you take bites, and it seals whatever you have in the jaw. So it just simplifies this significantly. And as you can see, we only have a couple of small incisions. And then the tumor is here, so we're going to take a couple of bites with this, and we're going to resect it. So when do we use this versus the radiofrequency ablation? This is called a minor liver resection, where you don't remove a lot of liver tissue. If the magnitude of the resection is not too big, then we prefer to cut it out. But if we have to remove half of the liver for a 1 centimeter tumor, you don't want to do that. In those cases, we generally like to burn those with a special needle. And this is how the cut surface of the liver looks like. So there are a couple of different treatment options that we have. Sometimes we leave it drain because you could have bile leaking later on, and that did not happen in this patient. But sometimes we leave it drain, it comes out a couple of days, and this is the specimen afterwards. Again, and this is how the incisions look afterwards. Again, for melanoma or sarcoma or breast cancer, I think removing a significant part of the liver is not justified because it's a systemic disease. So we like to do minimally invasive options, and at the Cleveland Clinic we have a lot of minimally invasive options. This is another patient with a different type of tumor. Again, a tumor located in the same spot. This is ultrasound, this is cancer, this is normal liver tissue. So with the ultrasound, we can then this is another lesion that is deep in the right side of the liver. And it's about 1 centimeter. So if you're in doubt, we can biopsy these spots and figure out what to do. Again, you mark where you're going to cut on the liver surface before you cut it. You can see the tumor is up here. But the bottom line is that we have a lot of minimally invasive options that we can help with the treatment of the liver tumors. The importance is, I think, recognizing these tumors. Dr. Singh has a screening program together with Dr. McNamara that the patients get ultrasounds periodically, and if anything is detected, then we do more sophisticated CT scans or MRIs to decide what treatment the patient would benefit from. I think like going into a screening program with these ultrasounds maybe every 6 months, every year, I think is very critical, because if we can catch these early, you can see that we have a lot of minimal invasive options that also seem to prolong the patient's survival as well. So, and then, the technology is evolving all the time. I showed you radiofrequency ablation. The new thing is microwave ablation. And this is more powerful and it's much faster. And I'll show you, the concept is the same as radiofrequency ablation. This is a different needle, has different properties. And the good thing is that once you treat the tumor, the chance of it coming back is much lower than radiofrequency ablation. And I'll show you a tumor case that you might find it useful, maybe helpful here. This is a patient with colon cancer, actually, but you can do it for any type of cancer, and I'll finish with this video. And this is the tumor here. 1 centimeter tumor, we find it with the ultrasound. If you wanted to cut it out, you would need to remove 50% of the liver. It's not justified. So this is the microwave needle. It doesn't have the umbrella-like prongs, but you place inside the needle, and once you run the energy, again, it's going to turn that area into scar tissue. And then you want to make sure that the tumor is covered by this ablation effect. This is another tumor we found with ultrasound, and you can treat it the same fashion. Again, by inserting the needle and running the energy, you can basically treat this tumor as well. And this is how it looks afterwards. You just have 2 small incisions. And we are doing more sophisticated stuff with the advance of technology. We can actually plan our treatments beforehand. This is a patient with a liver tumor here. This is colorectal cancer. Before surgery, we do a three-dimensional reconstructions. And then we can plan, like this red area is the area that I want to burn around the tumor. And when I put it into the software, it will tell me how I need to insert the needle and how long I need to treat it for. And this is what we did at the time of surgery. Insert the needle exactly as we planned. And this is the result. 1 week after surgery, this tumor is totally turned into scar tissue here. So I'm going to stop here because of the sake of time as well and get any questions you might have.
What would be the smallest size of tumor that you could biopsy, for example, to prove it's metastasis?
With ultrasound is very sensitive. I could do as small as like maybe 4 millimeters.
So that's
intraoperatively.
From outside.
We probably have to have 1 centimeter at least.
And the MRI will pick up something smaller, right?
Yes. MRI can go down as like 5 millimeters, I think.
Can you biopsy with the tumor easily?
I mean, we can do it surgically, but not, I think, radiologically. But one option is like if you have a suspicious lesion and MRI can determine that, we can take the patient to the operation room, biopsy. If it's positive, we treat. If not, we just, if we're done, the patient can go home the same day.
So that's what we were talking earlier today. With MRI, you're going to find small spots that are not easy necessarily biopsy. Then you may have laparotomy and find out you don't need it all. So that's an issue. It's hard to find earlier, smaller tumors. You may be doing false positive extra intervention. So that's something to also think about before we do the technique for imaging. So for example, when you survey patients with ultrasound, you pick up 1 centimeter down. With MRI, you must pick up 3 millimeter down. But you can't do much with 3 millimeter down.
I would say that if on imaging they're less than 1 centimeter, I would leave them alone and follow them. If they get larger, then you can do something about it. And as surgeons, I think like I tell my radiology and oncology partners that we can take care of all of it in one setting. Like if you have a lesion, yes, if it doesn't look like cancer, I would say let's do a biopsy. But if it's suspicious, without doing the biopsy beforehand, let's go to the operating room, let's do a laparoscopy. And if it's positive, we can know right there because we can do a frozen section, and we can treat it as one setting. And also with a 1 centimeter tumor, sometimes the radiologist cannot really target it well, percutaneously.
Thank you.
Thank you.